Before we start, during the break, there was some evidence that out of all this came some confusion, which is normal, you know. And the confusion was, we talk about preganglionic, postganglionic, sympathetic, parasympathetic, and now there's some confusion about, I see an anisocoria, how do I even start to think about whether it's parasympathetic or sympathetic? And just to do a quick encapsulation, remember that diagram I showed that you've got in the focal points, is that first thing you do is give more light on the situation, because that'll tell you whether the bigger pupil is the abnormal one or the smaller one. Remember, adding as much light as you can. If the anisocoria is accentuated, you know it's the sphincter problem, it's the dilator muscle. If the anisocoria gets less, then you should be considering things that cause a small pupil like Horner's, physiologic anisocoria. So that's my first move. Whenever I know when you see an anisocoria, it's like a deer caught in the headlights, like what do I do now? But add more light on the situation, that's my advice. And then you can start sorting out which is the abnormal pupil. So you first have to figure out, is it the larger one or the smaller one? So that help a little bit. Okay, we're going to switch streams to talk about OCT, because I know that most of you use that in your practice. And in neuro-ophthalmology, 20 years ago, we had to rely on, well, we still rely on important parts of the history in our exam, but now, like every subspecialty, we're incorporating information from OCT to add more. How can we see more things and get to the diagnosis faster and not make mistakes? And so I want to show you with cases what are the things that we use OCT for, and you'll be able to do it too. I know there's different manufacturers. I know Topcon's a big name in Europe, and they have a very good segmentation algorithm, so a lot of what I show will be applicable. Much of what I'll show here will be serous, will have some spectralis, but I'm not going to have much Topcon, but it should be easily translatable to what I'm going to show. So let's start with a little bit of the basics. First of all, we want to be able to look at those reports and know how to differentiate retinopathy from an optic neuropathy. And then we want to show some cases into how do you use the OCT of the optic nerve head. So using the disc area to your advantage, the rim diameter, and in the cases of optic nerve edema. And then we want to have some cases about how do you use the retinal ganglion cell analysis to help you sort out these cases, because the pattern there is very important. And then as we go through these cases, I'm going to bring up and insert artifacts, because like any test, the interpretation of the test is going to sometimes throw you off the track if you're not interpreting it correctly and not considering things that make the test look abnormal, but it's really not. So we're going to divide this into two parts, and it's going to be case-driven. On the left side are, the main applications on the outer retinal side. Obviously, if you're in the retina clinic, you're going to be looking at things like macular hole, perifoveal telangiectasia, cystoid edema, diabetic maculopathy, photoreceptor dystrophies, acquired photoreceptor dystrophies like big blind spot syndrome, Muse, Azor, CAR, and then things like traction. On the inner retina side, besides glaucoma, we've got optic neuropathy with retrograde degeneration of the ganglion cells. We've got developmental and genetic optic neuropathies like Leber's, autosomal dominant optic atrophy. We've got cases of papilledema. How are we going to use OCT? You might say, well, I can tell if there's papilledema on the fundus exam, but there are other clues that might help you differentiate pseudopapilledema from papilledema. How do you use it to follow somebody? How do you tell whether the edema is going down because they're getting better or because they're losing axons? And these are important questions. And then we're going to talk about hemianopsias that are both pre and post geniculate. and how that affects the OCT. So that's kind of an overview. Most of you know the anatomy. Just as a quick review, I've shown a histology slide and a high-resolution OCT. I'm not sure if the laser is working here. Oh, there's something else to point. The main points is that these high reflective lines that are in the outer retina, remember there's the ellipsoid zone, which is a high reflective junction between the outer segment and the inner segment. So that's where the kinocilium is. And the kinocilium is loaded with mitochondria, which have membrane, and so it makes it very highly reflective there. And so when you start to lose photoreceptors, you're going to lose thickness in the outer retina, and also you'll start to get disintegration of the ellipsoid zone. So that's kind of an important indication that something's happening in the outer retina. And then remember, in the inner retina, we've got the nerve fiber layer, which is highly reflective. And then most manufacturers lump the ganglion cell layer and the inner plexiform layer together as the ganglion cell complex, because the features are not great enough to very specifically differentiate the ganglion cell layer and the inner plexiform layer. And both of them are usually affected when the ganglion cell is lost because their dendrites affected. So most algorithms will combine those together, which is just fine. So those are the main layers that really concern ourselves with. And then, again, modern segmentation really can define almost all of these layers, and we'll go over cases why some layers are affected and some. So remember that when you do these scans, you're doing a volume scan of both the macula and over the disc. And the volume scan is necessary to do the segmentation. And so you're going to see thickness maps of the total retinal thickness in the ganglion cell layer, and most manufacturers will have a probability map, just like a visual field will tell you whether that thickness is outside of the 95th and 1st percentile of normal. So the probability plots in both the nerve fiber layer and the ganglion cell layer will help you know spatially which areas are thinner than what a normal should be. But the thickness color map is very helpful too, because sometimes you may have thinning, but it's not enough to drop into the abnormal probability, but it's abnormal. So we'll show some cases. So let's talk about, here's an interesting case I saw. And it was a 55-year-old man. So I work over in the Veterans Hospital too, besides university. And he's referred as a glaucoma suspect. And the story is that he lost his right eye in a motor vehicle accident way back in 1977. So he only has the left eye. And that's why there was a concern, is that the optometrist and the OCT of the nerve showed some cupping. And somebody with one eye, you're going to be a little more careful in terms of picking up glaucoma. And the pressure was still in normal range, but high end of normal. Vision was normal. He was not symptomatic at all. And remember, we only have the visual field of the left eye. And so here was the visual field. You have the visual field lecture. And you can see that there's not a whole lot. Maybe there's something, a few points here in the pattern that maybe, we're wondering if there's an arcuate defect, early glaucoma. This was repeated, and now there's really nothing there, but maybe a couple points here, so not a lot that looks that worrisome. He even had a 10-2, again, that really didn't show much of a problem, a few scattered points. And then someone got an OCT, so first they got the nerve fiber layer. And we don't have the other eye to compare. And you can see on the thickness plot, it doesn't really look anything that bad, but on the probability plot, you can see that blue area in the thickness plot looks like it's dropping into the abnormal range. So there's a question about it being thin. The rim is thinner there. So now there's a question, is it really kind of the start of glaucoma? And then we routinely get the ganglion cell macular scan in the nerve fiber layer in every patient. There's no reason not to. I mean, it's 1 second more scan. So we do that routinely. And this was the ganglion cell thickness plot. So what do you think about that?
The whole side is affected.
What do you mean the whole side is affected?
The whole side. One side.
One side,
Yeah.
okay. So why does that ring any bells, or does that create some worry? Or so you're saying it's almost, if you look at that thickness map, it looks like it's really, and which side is affected? The nasal retina side. So you got somebody that's referred for early glaucoma, and you got this ganglion cell layer, and you get a nasal. So what does that mean?
It should be thinner.
It's thinner there, but does it ring any bells in terms of, okay, beginning of glaucoma, but why does it look like it's a half of the ganglion cell layer like that? It's a bundle. So there's macular arcuate bundles, but those are like other arcuates, those don't respect the vertical. So that doesn't quite fit.
Is it retroactive atrophy?
Well, now you're wondering, is this part of a homonymous?
Yeah.
Is it
But the problem
retroactive
is we only have
atrophy?
one eye.
Yeah.
Is it retroactive?
Pardon?
Can it be retroactive? That something happened and it's the degeneration of the ganglion cell retroactive to
Like
something central.
Something retrograde,
Retrograde.
it has to be further back than the optic nerve, you're saying. Yeah, I agree. So you can see how that raised a level of suspicion where you wouldn't have had that suspicion without the ganglion cell layer. And that led to, okay, so you're thinking, wow, is there a pituitary tumor? So that led us to get a scan. And here's the sagittal section, and the radiologist called it normal. Here's the mid-sagittal, here's the aqueduct, here's the cephalus. There's no pituitary tumor, but there's something there that they call normal, and then with contrast, it's enhancing. So what is that? Huh? So if it's bleeding, it wouldn't enhance with contrast. A microadenoma. Macroadenoma is a big pituitary tumor, but there's nothing originating from the pituitary. You see space here. So here's the infundibulum. So the question is, what enhances in that location? And so when you get something like that and you notice something, the radiologist call it, you go up and talk to the radiologist and discuss. And then when I pointed that out to them, they agreed that something wasn't right. So that led to an angiogram. And that patient had a posterior cerebral artery aneurysm that was coiled and is an outpatient. It's doing well. So that could have gone the wrong direction if you hadn't been astute. So I show this case because as good of a neuro-ophthalmologist as we are, we rely on, visual tests, which wasn't that abnormal in this case. And if you go back and say, well, there were some points respecting the vertical. Yeah.
I don't understand how there was a effect on the ganglion cell on the OCT map, but not on the visual field.
Well,
it's not clearly on the visual field that there is a problem.
Well, let's go back for just a second to the first visual field. In retrospect,
Yeah, we call it like unspecific.
Yes, but it's specific.
But now if you start looking at it, you've got a cluster of points here that maybe we weren't really, but I guess the OCT drew our attention to that.
Yeah. Because when you repeat this, it was not the same month again. It was
Right,
like,
it comes and goes some,
yeah, exactly.
So, remember that this is a probability, and if you look at the actual numbers, they're down in that area, but maybe it didn't reach statistical significance. Now you start looking at all the ones were less than normal in that area. So the harder you look, the more you start noticing these little subtle things. So I think without an OCT, I wouldn't have done a scan or anything.
It's really interesting that you see a problem in OCT, but not in this, like in visual field.
Yeah, well, you do see it, but it's not, but
Yeah,
it's subtle.
It's not the problem I can see. Yeah, that's great.
You see, there's still didn't reach a probability, but I'm just saying that sometimes when it's an early, effect, you kind of blow it off. You don't really see it. So it takes two things, maybe structure and function, to call your attention to it. So that was, I think, a good learning point. 12th of August,
And
yeah.
the previous one?
A month before. Yeah. Well, in glaucoma, you see this all the time, fluctuation. So it's a behavioral test. It's not going to be the same every time.
But he didn't have any other symptoms.
No, he was completely asymptomatic.
So, it's very subtle.
Yeah, subtle and scary. It's a losing combination. Huh? Well, that's what I'm saying. The point is that sometimes, as good of ophthalmologists and neuro-ophthalmologists we are, we take whatever we can to get information to put it together to help. I mean, I'm not saying we're totally reliant on OCT, but it's a piece of information that you can easily get and use. Okay. In comes a 60-year-old. Now there's no mistaking it. There's temporal field loss, at least in this eye. And anybody can see that, right? So now it's your next test.
Was it only one eye?
Well, it was mainly only one eye.
The other one was...
So let's look at the OCT of that eye. Let's look at the ganglion cell layer thickness. Well, that's total retinal thickness there. So, so this is the right eye now. And if you look at that thickness plot, it doesn't look that much, not much of a pattern, but how about the B scan? What do you see there?
I see at which eye was this? Right eye, okay. As a nasal side of fovea,
Yes.
there is like an atrophy.
Where? Here, you mean?
Yes.
What is that line? Ellipsoid zone. So you still want to get an MRI scan?
No.
No.
But what's the reason? What's the cause?
Well, what do you think?
Center
Why?
artery occlusion.
Well, that's Azor.
It's an occlusion.
Well, because it's probably the only acquired, pattern degeneration of the outer retina that you can get. I put that into the big blind spot Azor mutes. That's called one big basket. Let's put it in. No, but a lot of them get better over time. And that's another important point, is that if you look at all the papers on retinitis, on Azor, in RP, when you lose that, you're going to continue to degenerate. In Azor or mutes, you get the ellipsoid zone back. So it doesn't mean you have permanent damage necessarily. So you still can get back the photoreceptor outer segments. And you do most of the time in mutes, for example. Azor, maybe not.
have a question there.
Yes,
Are these patients, do they have a relative afferent pupil defect in this eye?
yes they do. Because remember from the lecture this morning, yes, we've got melanopsin ganglion cells, but they also are activated by photoreceptors, right? And so that old adage that you don't get an RAPD with asymmetric retinal problems is not really true. You do get an RAPD.
Is it really wrong to do an MRI of the opticus nerve here? Because maybe a compression there could make the retina.
So we're going to go over this with some of the other cases, but you get retrograde degeneration into the inner retina, but you don't get transsynaptic into the outer retina.
Yeah.
And also the inner retina had a normal thickness here. So that's a good point to bring up, is that no, you don't get outer retinal thinning from a pregeniculate or a postgeniculate lesion. Good, good,
And
good.
I think the other eye is normal in this case.
Yes,
Yes.
yes it was.
What was the fundus image in this case?
So the fundus image was normal. Yeah. Okay, here's a 67-year-old female who sees constant gold sparkles in her vision for 2 weeks, more noticeable in dim light. She had some right arm swelling the last few months, 2 prior transient ischemic episodes with vertigo, hearing loss, and facial numbness. Those are medications. Vision was 20/20. Pupil exam and ocular motility were normal, and the slit lamp was normal. And she was pseudophakic. And so she had a visual field which came back like that. So very constricted fields, but she still maintained central vision of 20/20. So that was kind of unusual. Fundus exam was thought to be normal. Let's see if we can turn out these front lights. Can we? Whoops, don't want to do that. Oh, you guys will go to sleep when I did that. That's so this, view of fundus didn't look that abnormal when people first saw this woman.
There's a sign of that.
So some pigmentation there. So peripapillary pigmentary changes. Nerve fiber layer looked completely normal. Agreed? Yeah. Magnifying the fundus. Still, is there any abnormality or not? Not that obvious. There's a little bit of pigmentary change, but nothing that really gets your attention that much. And then here's the macular scan with a total retinal thickness now. This is not the ganglion cell, this is total retinal thickness. And just when you look at this, it should get your attention that you've got a normal thickness right in the perifoveal area, and you've got a huge amount of thinning of the total retina there. And when you look at the V scan here and at higher magnification, you notice that in the central 5 to 10 degrees where she had visual field, it looks quite normal, and then all of a sudden you're losing everything in the outer retina, which kind of corresponds to this normal area here, right? So, seems like it could be RP, but why did she start getting these gold sparkling lights for just the last couple weeks? It's kind of not a common feature in RP, although it kind of gives the appearance of RP. All right.
It looks like fluorescein.
Pardon? Yes. So she had serum submitted for antibodies, and she had the anti-recombinant antibodies. Remember, she had the right arm swelling, so she did have a right breast cancer and an autoimmune cancer-associated retinopathy. So here's where, you know, I think putting together the history and the symptoms and the OCT helps.
Is this a usual patient, like a typical patient?
Of CAR. Depends on what stage you get them. At the early stage, they may not have much structural loss and have an abnormal ERG.
Those kinds.
And then later on, as you get more drop out of the photoreceptors and you get thinning.
Did she take that cortisone?
So that's the good question, is how do you treat these patients, which is very controversial now. Because many of the oncologists feel this immune response is a good thing, right? Because your immune system is reacting against the cancer, it's cross-reacting against the retina. So do you suppress that immune response or not? And I don't think a final answer is in on this. That's a very good question. Some people are injecting intravitreal steroids, for example, so you're not suppressing the systemic immune system, so that's a possibility. Okay, here's a good question for you. Here's two patients. They both have an inferior altitudinal field defect. One is, and this has had it for some time, one is non-arteritic ischemic optic neuropathy, and the other is a branch retinal artery occlusion. So your job, our job together, is to try to understand how you can use the OCT to differentiate an artery occlusion from an old optic neuropathy. You're going to get this. I mean, you're going to see this. So it's not just a zebra I'm giving you. So first of all, if you look at so one of them's, the top one's the left eye, the bottom is the right eye. They both have a somewhat similar field defect. That's not helping you. How about looking at the nerve fiber layers? So that's the one on the panel on the right upper and the panel on the left upper here. So total, the thickness plot, color plot, both of them have superior loss of nerve fiber layer. So that's not going to help you differentiate them.
But the total.
Total thickness? Okay, let's look at that. Very good. Let's look at the ganglion cell first. Ganglion cell, that's not going to really help you either. Both of those are thin, right? That doesn't help. But I like your approach. So total retinal thickness, which we've got here and here, which one has the bigger difference between the upper and lower?
The lower one is the anterior one.
Right. And then on the B scan, what's the main difference you're seeing there?
More atrophy downwards.
But which layers? That's the key.
The afterwards.
Yes.
They don't.
Nuclear layer.
But what inner layer, what differentiates the two? Not just the amount, well, the amount of thickness, yes, but what's present in the upper one that's not present in the lower one?
Ganglion.
Well, the ganglion cell layer is thin in both of them. We already established that, right? As we've seen the ganglion cell plot. But what other layer is affected?
Actually, the inner nuclear and outer nuclear is not seen.
The outer nuclear is seen.
In the lower one,
Yeah, the outer nuclear is seen. But the inner nuclear, you're absolutely right. Inner nuclear layer, and that is what cells are those? Bipolar cells. Okay. So why is the bipolar cell layer and the ganglion cell and nerve fiber layer affected in BRAO? But in an optic neuropathy, only the nerve fiber layer and ganglion cell layer.
Because there's a supply from the corridor.
You're warm, but not quite there. So let's. Blood supply. Blood supply to the inner retina is from branches of the central retinal artery, right? And those branches supply the nerve fiber layer, the ganglion cell layer, and the bipolar cell layer. So if you have a vascular insult to the inner retina, you're going to affect all those layers. If you have an optic neuropathy, you will not affect the bipolar cell layer. You do not get transsynaptic degeneration into the internuclear layer. So two things are going to help you. Looking at the total retinal thickness, because since you're losing RNFL, ganglion cell, and bipolar cell layer, the total thickness is going to be much thinner in an artery occlusion after the atrophy's occurred. But in an optic neuropathy, you'll still get thinning, but not as much because you're losing 2 of the 3 layers, not all 3. This is a case showing the progression during the acute 1 month, 2 months, 3 months. Now obviously, it's easy during the acute phase because you get edema, and you're going to see that in the fundus exam, and you're going to see thickening of all those layers, right? But then after the atrophy takes place, that's when you might see the patient. And that's where you're trying to differentiate an optic neuropathy from a vascular. And so you might say, well, what's the big deal? Why do you need to do that? Well, if it's a branch artery occlusion, then you're going for embolic risk factors, right? Potential for stroke risk factors. If it's optic neuropathy and AION, then you're looking for hyperperfusion risk factors and nocturnal, blood pressure drops and, obstructive sleep apnea, and those are type of risk factors. So it's not trivial in terms of what you're going to try to do to prevent something else from happening. Okay. Let's talk about some of the artifacts. Maybe. We've already went through the normal OCT, and just a couple things. What's the information you've got at your disposal? Remember, you've also got the optic disc analysis, which gives the disc area. So this black line, how do they define the disc area? In the B scans going through the optic nerve, the algorithm finds where Bruch's membrane ends. And that defines the neural canal opening, where the axons are coming through. So histologically and on OCT, that's the way all manufacturers find the disc area. It's where Bruch's membrane is ending. So you have to make sure the algorithm has done it correctly, and it looks like it has. And then, how do you find the rim border? And so almost all the manufacturers look at the surface, and they look at the point that has the shortest distance to the end of Bruch's membrane. And that point is the red point. And they go around, with B scans and look at that circumferentially. So that's how the rim border is defined. And then once you define that, then you've got a rim area, you've got a cup to disc ratio. So it's using this segmentation to give you all those things, quantitatively. And it plots the rim thickness, just like the RNFL plot. This is plotting the rim thickness here. So if you have increased cupping, you'll see the rim starting to thin, just like the RNFL. So that's what that plot's about. This plot you're used to, that's the circular scan. And it's going around the clock, and you're looking at the thickness, and you're superimposing the right and the left eye. So the right's the solid, one's the left eye. And in most cases, it's very symmetric. So if you see any asymmetry, you may want to look and see whether that turned out to be a probability that was abnormal. In this case, it's not. And then it's good to look at these B scans to make sure the algorithm segmented the scan correctly. So if it doesn't do that correctly, all these color probability plots and these quantifications can be way off. It's not segmenting it correctly. So you have to kind of look at the B scan to make sure that that looks correct. Same thing with the ganglion cell layer, making sure the segmentation looks reasonable. It's excluding the nerve fiber layer, so you're just looking at the ganglion cell interplexiform layer thickness. And it gives a probability plot here too, on a pixel basis and on a sector basis. So here's a 76-year-old with normal tension glaucoma and asteroid hyalosis. And I want to point out what are some potential artifacts here. So first of all, on the color plot of the RNFL, you see where the black is? So when you see black there, it's not finding any thickness at all. So something's not right when you're not seeing that. And so there are different reasons why that might happen. Sometimes the segmentation's way off, and you should, whenever you see black like that on the scan, you should mean it's not trustworthy in that location. And what's happened here is that the signal strength, when you see the arrow up there, is greatly reduced in the right eye because of the asteroid hyalosis. So it's preventing a lot of the signal, a lot of the light, coherent light, from getting to the retina in as high of an intensity as it needs to capture a good image. So signal strength is one thing to be on the lookout for. Then I showed you that area where the arrow's pointing where it's black. And that location right here is why the nerve fiber layer is dropped down here. So you see that's an artifact. And that artifact is also the reason why that's very abnormally thin. This is a patient with glaucoma, but I'm just trying to emphasize that when you interpret these things, you have to decide what's due to the pathology and what's due to an artifact. So you have to look at different parts of the scan to interpret this correctly. Okay, so reduction in signal strength can lead to a segmentation artifact. Any kind of media opacity can do this. So cataract, dry eye, sometimes just putting drops in the eye and repeating the scan will help. Vitreous opacities. And so anytime you see a signal strength that's abnormal, you have to watch out for these errors. Here's where you can see it's very extreme. Signal strength is only 3 out of 10. But yet, it seemed to affect the right eye, but not the left eye, but the signal strength is just as bad. So sometimes it can overcome it, other times it can't. You can see, like I said, whenever you see black there, that's a warning sign. Here's the patient with papilledema, and you can see the algorithm can't find the correct thickness. The swelling is interfering with the segmentation. And that's why if you look at the B scan and it's not following the layers, don't fall into the trap of over-interpreting that. You can see on the left eye, there's a lot of vitreoretinal traction, and it's finding the vitreoretinal traction there as the layer, but it's not. So, these are just things to watch on the B scan for. Okay, I want to show some cases of when you do have swelling of the nerve fiber layer, how can you use the ganglion cell layer to help you interpret whether there's a problem more than just the swelling, that they're losing accents or not. So here's a 44-year-old male with decrease in vision in the right eye 2 months ago on awakening, and then recently in the left eye. So 2 months ago, noticed vision loss on awakening in the right eye, and then what brought him to medical attention is now he just noticed vision loss in the left eye. What do you think about the fundus exam? What? Hypoperfusion?
No, but this is defined in the right eye. The right eye is defined nasally.
Right, it looks like it's obscured a little bit on the nasal side on the right eye. Temporally, you can see the border. In the left nerve, which is the one that was more recently involved, it still looks like it's not very well defined.
Just papillary, right? Papillary.
So you're wondering if it's papilledema or edema. Here's the visual field, Goldman visual field. So in the right eye, which was the one that was 2 months ago, there's a big central scotoma that's dense. In the left eye, there's a relative scotoma that's centrally. So there's central loss. If it was papilledema from raised intracranial pressure, is that the type of visual field loss that you'd expect, do you think? Central scotoma? Not usually. It's more nasal loss or arcuate loss. So something's not quite right here.
Some toxic neuropathy or something?
So toxic neuropathy, like what kind of toxic neuropathy would cause disc edema and central loss? There's only one type I can think of, maybe.
I don't know.
Methanol toxicity.
Actually, idiopathic intracranial hypertension can make a central scotoma.
It's not very common.
Yeah.
I mean, maybe if there's fluid going into the macula, but that's not the typical field defect you'd see. And with the retinal nerve fiber layer plot, would you say that's normal or abnormal? What does it mean when these are white? You know, before they were all green. Huh? No. It means it's thicker than normal. So if it's above the green, then they make it white. So that means it's above the 95th percentile. If it's yellow, it's below the 5th percentile. So here they got it for you right here. So that means it's thicker than normal. We already said it looked edematous, so that's not really anything you didn't know. Here's the ganglion cell analysis. So remember, this was the eye that was affected 2 months ago. So you've already got ganglion cell layer loss, which you can see on the color plot and the probability plot. And you've got normal ganglion cell thickness, but this was the eye that is acute.
Yeah.
Okay, so now you've got, first the right eye was involved, and it looks a little bit swollen on the nasal side, and you've got ganglion cell loss in the central scotoma.
Started to be atrophic after edema. It is the beginning of optic nerve atrophy after papillary edema, and the same thing going to the left eye. And if it will continue like this, it will be bilateral optic atrophy.
So I agree that it's probably going the route of bilateral atrophy. But do you think that amount of edema, was responsible for papilledema causing a central scotoma? That's what doesn't quite fit in my mind, is that that's not the typical field defect you get with that amount of edema.
Did you get any ST?
And also, the vision was down too. And yeah, we had the OCT of the macula. That's with the ganglion cell layer, but there was no fluid there, if that's what you're asking.
Any other symptoms?
No, it's just a sequential vision loss.
LP, any serology?
Thank you. So that patient had LHON. Okay. So I just put that as an example of how you could have central loss and then ganglion cell loss in the setting of what looks like a swollen nerve. So Leber's hereditary optic neuropathy would be one example. Because you're going to see them at different points, and Dr. Newman's going to lecture on this in the next day. And depend on when you see them, whether one eye's involved or the second eye just got involved, that brought in the medical attention, whether you see one eye being atrophic and the other eye now looking swollen. And so the OCT can help point you in that direction, especially if there's central loss and atrophy in the setting of a swollen nerve that was sequential.
We take a 5-minute break.
All right, thank you. Sounded good. All right, here's a 37-year-old woman who had worsening of vision in both eyes. So 2200 in the right eye, 2025 in the left eye. And you can see her visual fields showing a lot of central loss, inferior loss, arcuate loss with the automated perimetry. In the left eye, arcuate loss, both superior and inferiorly. And what would you say about the nerves in this one? Well, they don't look atrophic, they look a little swollen, don't they? And your OCT kind of confirms that. Especially more so in the left, in terms of and the ganglion cell layer is going in the wrong direction, so that's really thin. So here's a situation again. These are the cases that you've got the combination of what looks like edema plus ganglion cell loss. And so, and she had fairly acute worsening of vision in both eyes. So again, you might say, well, is this papilledema? And she have raised intracranial pressure, but again, I'm not saying you can't get central loss with IH or raised intracranial pressure. It's just unusual to get this amount with that amount of disc edema. Usually the cases that are what people call fulminant or rapidly progressive have a lot of disc edema, like grade 4 or grade 5. So we've got this situation again. Instead of this wasn't sequential. This was kind of bilateral, progressive, and you've got a combination of both of these things. So I'm just getting you to think about what are the things that would come to mind that would do that could cause damage to the ganglion cell layer and axoplasmic flow stasis. So this was her MRI scan. What do you think of that?
Isn't it called trail tracks?
Yes.
On the
So you've got enhancement of the nerve sheets on both sides. And you can see that kind of here and here. So what causes that?
Meningioma.
Yes. So she had bilateral optic nerve sheath meningioma. Sometimes it happens. But what's an important question you should ask a woman who's 37 who has, well, that doesn't usually cause a bilateral meningioma, but meningiomas that are progressing fairly rapidly, do you know of any risk factor for that to happen? What's OCT? Yes. So remember, most meningiomas have progesterone receptors more than estrogen receptors. So it's very important to ask the patients if they're on supplementation progesterone, either birth control or in postmenopausal women all taking progesterone, because that often accelerates the meningioma growth. So, and then, do you know the mechanism of the disc edema is kind of interesting. So, be a combination of, you get, let me ask it another way. Do you know why in an optic nerve sheath meningioma sometimes you see collateral vessels on the nerve? Yes, they're really collaterals. Shunts go from arterial to vein. Collaterals are vein to vein. So technically they're collaterals. But do you know the mechanism of why that happens? What's the most common condition where you see that?
Sphenoid meningioma.
No, even more common.
CRDO.
Yes, CRDO. So that's venous stasis, right? So why do you think you might see venous stasis in the setting of an optic nerve sheath meningioma?
Pressing on the venous system.
Absolutely. That's where the vein exits the nerve, is right through the sheath. And that's probably one of the mechanisms of the edematous appearance of the nerve too, just like you see some edema in a venous stasis too. So it could be some axoplasmic flow, but it also could be leakage. So that's a good point.
Before I saw the scans, I would think it was NMO.
Before you see the scan, well, NMO, MOG would usually cause optic disc edema. NMO is most likely to cause disc edema, and also the visual loss is very abrupt usually. She had kind of a rapidly progressive, but anti-MOG antibody, there you could have swelling. But again, like you said, before you see the MRI, but the MRI kind of goes against that because the nerve itself's not really enhancing. But that would be reasonable. It's a bilateral optic neuritis, but again, most of the time it's going to be, for that kind of swelling, more MOG than NMO. Okay, so here's a patient who did have idiopathic intracranial hypertension. She also had some psychiatric problems, and so it was very hard to decide whether those visual fields are trustworthy or not. So that made the whole thing more complicated. And obviously there's a lot of swelling there. You could see that from the fundus photos. The OCT is not really helping you so much there. And then here was the ganglion cell analysis, which seemed to show a lot of thinning. So in this setting of raised intracranial pressure, when you're seeing ganglion cell loss in the setting of disc edema, that's a bad sign. And those patients probably need to be treated pretty aggressively. So this is kind of on my list of differential diagnosis of RNFL thickening in the presence of ganglion cell loss. We talked about Leber's hereditary optic neuropathy. We talked about nerve sheath meningioma. NION, because the ganglion cells, show a picture later, that starts thinning in about 8 days, so it happens fairly quickly, and it's almost maximum within a month after the injury. So you could still have swelling of the nerve from a NION. If you saw them a couple weeks down the line, they would have thinning already. Graves' compressive optic neuropathy, where there's already ganglion cell loss and you're getting an orbital compression which causes swelling. We talked about papilledema from any cause of raised pressure with visual field loss. And then, just like you said, recurrent acute optic neuritis can sometimes, recurrent meaning they already had ganglion cell thinning from a previous episode, and now they've got a new episode, and even though you've seen it within a few days, there's thinning. That kind of tells you they had something before.
So what is the cause of the retinal NFL? The thickening of the retinal fiber layer, is it the axoplasmic stasis?
In what disorder?
In these cases.
Well, I think
Graves'
different mechanisms. So in Graves' disease, I think that some people think that you're trapping the CSF in the orbital region, you're compressing at the apex, so everything coming forward is still under high pressure. And so you're getting an axoplasmic flow. As if you have raised intracranial pressure, but you're trapping the pressure. That's, some people think that's the mechanism. Leber's, remember, it's many people, I think Dr. Newman will speak to this later, is mitochondrial are important for axoplasmic flow. So if you have a mitochondrial problem, you can have axoplasmic flow stasis, and then you have an appearance of a swollen nerve. Papilledema. So we know we have axoplasmic flow in that case. NION, ischemia causes axoplasmic flow stasis, so that's the mechanism there. And optic neuritis, an inflammatory optic neuropathy, and conduction block, you're going to have swelling. Now, even if you have a lesion with acute optic neuritis, intracranial optic nerve, you can still get enough axoplasmic flow that at the nerve head it looks swollen. So it doesn't necessarily have to be that the inflammation is right adjacent to the exit of the nerve. It can be even further back and still get a swollen nerve. Okay, good. Just a couple artifacts in the setting of disc edema. Be careful. As we said, when you have a lot of swelling of the nerve, the algorithm that finds those layers often fails. And you can kind of see that when you look at that color plot, when it looks all folded like that. It makes you think the algorithm, and if you look at the B scans, you can see it can't find where the layers are. That the layer's too distorted for it to find an interface. So just be aware of that these aren't that accurate in the setting of a very swollen nerve head. Another artifact to be aware of is, you see how in this one it looks like the ganglion cell layer is thin by the probability plot? But if you look up there, it's kind of weird looking because you've got fluid going into the macula. And the point I want to make is that, see how these algorithms are affected by what's happening at the nerve? They're not finding the borders correctly. And so sometimes the ganglion cell layer analysis is not accurate. And you have to really look at the B scan and see where it's picking the layers, because you might misinterpret it as thinning when it really isn't. Here's another clue. See, it gives the average thickness and also the minimum thickness within that area of scan. The ganglion cell layer cannot thin really much less than 40 microns because there's glial cells. I mean, if you have an NLPI and transect the optic nerve, it just can't get thinner, much thinner than 40. So another clue that there's an artifact of the segmentation is if you see a value that's below 40 in the minimum thickness, start thinking that it's not trustworthy, the segmentation. So we at Iowa, the image analysis group, developed a way of doing this in 3D that overcomes a lot of that, and we've used that in some of these cases, and we're hoping the manufacturers will take that and use it. So that patient had a 3-month follow-up after the disc edema went down, and you can see how the ganglion cell layer doesn't look as bad as it was before. Like it did there, same patient. Sorry. Take a breath. I'm going to go to part 2. If you can take it. There's another interesting aspect. A lot of what we're doing and some of the manufacturers now are incorporating is that instead of trying to do the nerve fiber layer thickness, if you do the total thickness, which is easy to find the border there, against the pigment epithelial layer and just drop a line through there, you get a volume scan. And just showing how the volume of the optic nerve head can be more robustly correlated with the amount of papilledema. And I'm also showing an interesting thing, I don't know if you've noticed in some of your scans, if you get B scans through the optic nerve head, not just a circular scan, but going through the nerve head, and if you look at Bruch's membrane and the deformation of Bruch's membrane, if there's a big pressure gradient between the nerve and the vitreous, it pushes Bruch's membrane towards the vitreous. So that's a sign that there's raised intracranial pressure, as opposed to the normal configuration, which is neutral or pointing backwards, especially in glaucoma, pointing backwards. And sometimes this is helpful for following patients. So Bruch's membrane, as the pressure comes down, Bruch's membrane deformation will become less. So, and this is just showing the use of volume, which is very robust, even when the nerve fiber layer fails. Okay, here's a 32-year-old with headaches. Nerve fiber layer is maybe a little bit thicker than normal. But here's another clue that this is papilledema. So here's the total macular thickness. And there's some clues here that this might be papilledema versus pseudopapilledema. Let me make you see it a little bit better.
The nasal side is a little bit ill-defined, right?
Pardon?
The nasal side is a little bit ill-defined on the left side.
Yes,
The left side.
but you see this kind of pattern here? So obviously there's some fluid there. And if you use the en face view or the SLO view, you can follow this fluid. And sometimes you'll even see it leaves pigmentary changes. So after the fluid goes away, they make it down to 20/30. Eventually they'll get down to 20/20 if it, eventually with time. But some of the submacular fluid from disc edema can cause a decrease in vision too. And you can see footprints that they've had previous fluid if you look carefully here. The last part about papilledema is it's been reported recently about the appearance of retinal and choroidal folds in papilledema. And the reason this is important is that pseudopapilledema, so far we've not found any evidence that it causes any wrinkles or folds. So these are divided into what are called peripapillary wrinkles, retinal folds, and choroidal folds. Peripapillary wrinkles are the circumferential wrinkles. And you can get that in any type of edema, whether it's NION or raised intracranial pressure, but we've never seen this in pseudopapilledema. And what differentiates other forms of edema from raised intracranial pressure is when you see radial folds, so going in that direction, that's usually deformation of the nerve from raised intracranial pressure. So radial folds is somewhat more specific for papilledema. And if you look at the en face view, so if you have a volume scan, most of these instruments, you can look at the en face, you'll see the folds much more evident. So it's another sign that you can use to your advantage. That sometimes they're not that obvious on the fundus photo, but on the OCT en face, you can see them much easier. And here's choroidal folds, which is not wrinkles in the retina, but at the deeper layer. Those are not as common.
Sorry, but was it just papilledema or was it optic disc edema also?
So when you have the radial folds, it's papilledema. If you have just the peripapillary wrinkles, it could be either. But for sure, don't make a diagnosis at this point of pseudopapilledema if you see wrinkles. We haven't seen pseudopapilledema yet that have wrinkles. All right, here's a 43-year-old that presents with a homonymous visual field defect following a motor vehicle accident that occurred 6 months ago. And obviously she has a dense, complete homonymous. And there's the ganglion cell layer. So that's obvious, right? And if you look at the coronal sections, you'll see that the optic tract on that side, so this is just posterior to the chiasm, a blow-up of this area, is a thinned optic tract. So that's a good example of an optic tract, and as we talked about in the pupil lecture, they should have an RAPD. And which eye of these two should she have the RAPD in?
The right eye.
Right, because that's the one with the nasal retina or temporal field loss. So the eye with the temporal field loss is RAPD. Good. Okay, here's a 32-year-old woman, had painless vision loss for 3 weeks. She describes missing the beginning of words when she's reading. So that's a clue. She also describes heat-induced vision loss in the left eye. So whenever she has a hot shower, her vision goes down in that eye. But visual acuity at rest is 20/20. So what's that history sound like?
Optic neuritis or something.
Right. Now that was her visual field.
Pie in the sky, tempura.
Okay, so pie in the sky, but let's look at the probability plot. Is it still pie in the sky?
Bigger than
It's a bigger piece of pie than... Now we're getting hungry.
Very good.
But this is acute, but yet we're seeing some optic atrophy in the left eye.
So what does that tell you? So she's got an acute homonymous loss. She's got UTAS phenomena, but now you're seeing atrophy in the left eye. Well, why would it be atrophy at this point? It's acute.
We'll come back to that.
Why it's acute? I mean,
Or her vision loss, her trouble with reading words.
Words and missing things to the side was acute.
maybe she noticed that acutely, but she had trouble
Could be,
before.
could be.
Since it's quite good.
But this was her OCT testing. This is just within a couple of days of when she noticed it. So at this time, we really don't see a homonymous ganglion cell loss. It looks kind of diffuse. So now what do you think? Why would that be? Well, what was your original diagnosis before we had the homonymous loss? Optic neuritis, okay. But now we've got homonymous loss, but at the acute stage when she noticed it, she's already showing ganglion cell loss within just a day of when she had the symptoms. What does that tell you? Yeah. She probably had a previous episode of optic neuritis that never came to medical attention, and now we're seeing something on top of that. Very good. Wait, we're not done yet. That homonymous field loss resolved within, a couple weeks. So why would that be? Where was the lesion and why did it resolve?
It was central.
So in the setting of demyelinating disease history,
Post-viral?
well, in the setting of demyelinating disease history with a new homonymous loss that also goes away with time, where do you think the lesion was? Huh? Yeah, where would be somewhere? Somewhere.
Optic tract.
Optic radiation?
Optic radiation or,
Like a slope?
well, that was below the horizontal too, not just above. Or it could be the optic tract too, right? So, but here's her OCT. This is 3 weeks later. So acutely, she didn't show, this is interesting, she didn't show the homonymous thinning, right? But she had a field defect. Now the field defect went away, but in spite of the return of visual field, she has evidence that it was a tract lesion, because if it's pregeniculate to get thinning that fast. So she had a demyelinating lesion of the optic tract. And just like in optic neuritis, you have a return of visual field, but you see footprints of ganglion cell loss. So think of that as a footprint of previous demyelination. So she had MS. Here's a patient, well, she had previous optic neuritis in both eyes and now had a new tract lesion. That's how I put it together, based on the ganglion cell. See, the ganglion cell helps tell you the story of what the footprints were at the time she presented. There was something there before in each eye, and now she's got another area of demyelination, another location.
And how does the optic disc look like?
Remember, there was some
Atrophy.
atrophy on the left eye, another sign that something had happened prior to what brought her to medical attention. Like you said, there's a possibility that she'd had it for many, many months and just hadn't noticed it. But when people start missing letters to the side, usually that brings it to attention pretty fast in terms of that and getting the history. This is a patient that we're lucky enough, well, not for the patient lucky. He had a traumatic optic neuropathy, almost complete vision loss, and he was local. So I was able to bring him back quickly at different intervals to follow the atrophy. And what was really surprising to me is that even at about 8 days, we started to see that the layer was thinning, the ganglion cell complex, which sounds like, how can you get thinning that early? And this, we've observed this in some other patients too. And experimental models of optic nerve lesions in animals, first thing that happens is you've got the dendrites from the ganglion cell, they retract to the cell body. So where are the dendrites of the ganglion cells located? What layer did we say? Interplexiform layer. Remember we said the ganglion cell layer complex algorithm combines the plexiform layer and the soma layer. So one possible explanation for the early thinning is you get retraction of the dendrites before you even lose the soma, is some of the early thinning, because that's part of the complex layer. Because it's hard to explain getting atrophy that soon. But the experimental models seem to indicate this retraction. And so the ganglion cell layer actually thins fairly fast. You know, here's two patients that had optic neuritis, and the RNFL thins after that. So the ganglion cell layer often reaches its minimum at 4 to 6 weeks, whereas the nerve fiber layer keeps thinning, not till 3 to 6 months do you sometimes reach the final asymptote. So it tells you about the timing of the lesion if you're seeing the patient at a certain time. If you're just starting to get a little bit of nerve fiber layer loss, but there's a lot of ganglion cell layer loss, you kind of can figure out about when the lesion happened. So it kind of helps that regard. Okay, this is really interesting. This is a patient, an MS patient, who had a left pericentral homonymous scotoma. So this is very, localized and homonymous. And there was thinning in a corresponding location in the ganglion cell layer. Now, that's hard to get a tract lesion to give that small of a defect. Usually it'd have to be post-geniculate, but yet we're showing ganglion cell layer thinning. So I published a paper with my colleague at Lausanne a couple of years ago, and we had a really interesting case of arteriovenous malformation in the occipital lobe that was treated, and at the time of treatment the patient had an immediate homonymous scotoma similar to this patient that we saw. And what was interesting is when we followed that patient over time, they eventually had dieback into the retina even though the lesion was way back here. And so you can have retrograde transsynaptic degeneration into the retina, but it takes a while. And this was a patient that I've been following at Iowa who, let me show you, I'm going to go back to this. She had occipital meningioma, and this was her pre-resection homonymous field defect, and she had no prior ganglion cell layer thinning, okay, due to the lesion. But she had it resected, and the scotoma was bigger, right? And it came in closer to fixation. And I've been following her in terms of her ganglion cell layer. And what was interesting is you can see that at about 16 months after the resection, she's starting to get dieback into the retina. So it differentiates a pre-geniculate from a post-geniculate ganglion cell thinning is the timing. It seems to take at least 1.5 to 2 years before you see it dying back into the retina. So if you see some patients that have had occipital strokes, 2 years ago, you're going to see a homonymous pattern in the ganglion cell layer. It just takes longer. It's very interesting. The reason that has some importance is think about MS, for example. A lot of the population studies in MS and OCT show thinning of the ganglion cell layer, even though they're asymptomatic and never had optic neuritis. And some of those patients probably have had demyelination on both sides post-geniculate, and you can't appreciate that it's a bilateral homonymous, but it looks like diffuse loss. So some of those patients have had previous optic neuritis. Some of them may have had demyelinating lesions in the visual radiations, in the white matter there. So it kind of helps explain some of these things that are being seen. The last couple slides, I want to, this is from Don Hood, it's a good colleague of mine at Columbia in New York. And he studied, glaucoma extensively with OCT and visual fields. And this is just to remind you, if you took 1,000 glaucoma patients, the most vulnerable, the most common zone for nerve fiber layer loss is in this area right here that we call the vulnerable zone. And that involves both arcuate bundles that you're used to seeing on the 24-2 and macular arcuate bundles that will affect the ganglion cell layer. And if you do a 24-2, remember those are 6-degree spacing grid. And you may not even pick up a macular arcuate. It may fall in between the points. And that's why a lot of people are using 10-2s on a lot of these glaucoma patients, because you pick up, especially if you see it with an OCT, the arcuate bundle, and you can pick these up on the ganglion cell or on the nerve fiber layer. So it's kind of an important point to remember. And we were talking about using the Amsler grid for visual field when we did the confrontation yesterday. And that's another good use on those glaucoma patients. You'll see that you can pick up these macular arcuates within the central 10 degrees that just come right up to fixation, but don't include fixation until late in the stage. So this is a typical case of glaucoma, where this most vulnerable zone is inferior arcuate bundle, which would be a superior arcuate field defect. On the OCT, you see the rim thinning. See that? Right where you're losing the rim, right where the nerve fiber bundle is gone. And in the other eye, you can see some thinning there. So in glaucoma, like other optic neuropathies, look for a correlation between where you're losing the nerve fiber layer and thinning of the rim in that location, which the OCT will give you on exam and also your fundus exam. And then this is a kind of example of these type of arcuate macular bundles that you'll see in glaucoma. Sometimes they'll be so extensive, that it'll be diffuse, but this will be the earlier stage where it's affecting just one arcuate bundle. So here's a 63-year-old referred for decreased peripheral vision and possible glaucoma. So it looks like pretty large cups, right? And that was the visual field. So it looks like maybe possible arcuate or not. What if you just looked at the 1,2E isopter? This is getting to your question. So this is a glaucoma suspect. Now look at the ganglion cell layer.
Bitemporal?
Yeah, well, binasal retina and bitemporal field defects. So you're asking the question, which glaucoma patients do you want to image? Obviously not all of them. but ones that are showing this type of pattern, you know, if you go back to the visual field, it doesn't look so arcuate anymore. You know, it kind of starting to respect the vertical meridian, not so much an arcuate. But that's where the ganglion cell layer can help point you in the right direction. So, yeah, they had, and this is a typical one where they're stuck in the glaucoma clinic for a while, then finally, you know, either because the visual field's starting to show something more obvious or someone gets a ganglion cell layer analysis. You didn't appreciate that with the nerve fiber layer analysis, right? That could be glaucoma. So takeaway points on the ganglion cell. Early homonymous ganglion cell thinning indicates a tract or pregeniculate lesion, but postgeniculate lesions can sometimes cause delayed homonymous thinning. Nasal thinning indicates chiasmal damage, so that's where it can really help you, I think, in terms of, you know, going in the right direction in your workup. But there's artifacts of ganglion cell segmentation, and some people call this propeller sign. You see how that pattern of thickness, you've got a normal area and then it kind of looks not like a pathologic, it looks like some kind of artifact when you see that kind of thickness pattern. So be aware of those type of things. Some people call it, looks like a plane's propeller. And again, if you see that the thinnest part of the ganglion cell layer drops below 40, that's indicates an artifact of segmentation. Just one or two more cases, then we'll break. 21-year-old man referred for glaucoma because of the optic nerve appearance. Large cups with normal visual fields. But the OCT RNFL was abnormal, that's why they were referred in. So pretty normal visual field, let's say, 24-2. Okay, now the question is, how do you interpret this? So, on one hand, it looks like a very thin rim, and it's kind of looking like it's dropping into the red region. Now, is there anything else unusual? Look at all the information there. Do you know why, on that disc analysis, do you know why on the reports they make it gray? Do you notice it's gray there? Instead of green or, you know, yellow or red, it's gray there. There's a reason why they make it gray. That means that the disc area is outside of the normal range, and so all of the parameters for cupping can't be used. So that disc area is almost 3 millimeters squared. Normal is about 1.75. This is a paper from Chris Gerken's group at Alabama, and it's showing what's the frequency distribution of disc area in, you know, the normal population. So our patient out here is way outside of the normal range. And this shows the relationship between disc area and cup to disc ratio. So the reason this is helpful, I know you see this all the time in your clinic. A patient comes in referred for large cups. Is it physiologic cupping or is it early glaucoma? Especially if it's asymmetric. Look at the disc area. If the disc area is a lot larger on the side with the increased cup, and the other side is a normal disc area with a normal cup, you almost know that it's not acquired, it's developmental. So keep in mind that obviously the larger the size opening, if you have 1.3 million axons going through a larger opening, you've got plenty of room, right? As opposed to a smaller opening when they're squished together and you have no cup. So remember that the cupping is proportional to the amount of disc area usually. So this was a case of megapapilla. And another interesting aspect, you're probably wondering, what's this? you see where the normal peaks are for the normal range, for the normal population, where they're located? Right. But the location of those peaks is where the, that signifies where the arcuate bundles are expected, what angle they're supposed to come in. So normally it should be about right here. And hyperopic eyes often have an angle coming in more vertically. And myopic eyes often have it coming this way. So some people call this peak shifting. If the peaks are shifted inwards, that means they're coming in, the arcuate's coming in vertical. It's shifting it. And that's why you get this coming into the red range. If that peak was in the normal location, you wouldn't have. So people call this red disease because they refer to glaucoma, and it's really an artifact of their axial eye length. Here's one where you see this red disease.
Hyperplasia, right?
Well, this one is a myopic eye, okay? And see how the peaks are shifted in that direction, because the arcuate bundles come in like that, and it's expecting it where the black arrows are. So that's going in the opposite direction. So these are the most common artifacts you see due to axial eye length, so be on the lookout for that. Here's a more unusual one. You see how the pattern looks kind of strange of where it's red. Here's a fundus photo. You see anything funny there? And also, what's funny about the visual field? So remember we were trying to find each other's blind spot yesterday? And if you have this patient, you wouldn't be able to find it because you're not expecting it to be where it is. So it's above where it should be in the right eye, and it's below where it should be in the left eye. And what on the fundus photo accounts for that?
Not on the same line.
Huh?
They are not on the same line.
Yeah, why aren't they?
Slight torsion.
That's right. So that person had a skew deviation causing torsion of both eyes. And if you go back and look at this again, so you see how the bundles are rotated so they're in the wrong location where you're expecting them to be, because the eye's rotated. That can also happen if the person's sitting in the OCT machine, they're tilting the... Okay, maybe one more. Here's a 65-year-old found to have superior field loss in both eyes by our optometrist, and is referred as a glaucoma suspect. So there's the field defects. The patient wasn't aware of anything. We didn't know why they were being sent. Okay, what do you think about this OCT? How about the top two panels? So think about the visual field. What do you see there? Huh? Right, thin inferiorly in terms of the nerve fiber layer. Now look at the disc segmentation. What's unusual about the disc? It's small and misshapen. Matter of fact, it looks like there's not much disc in the inferior portion. Not just tilted.
Hypoplasia.
Yes, so that's kind of on the spectrum of hypoplasia and segmental hypoplasia, right? So see how the disc analysis can help you putting it together with a nerve fiber layer. You kind of know it's not acquired, it's developmental when you see a disc that looks like that, you know, that's small and the bottom part's missing. Okay. And again, this distribution of disc area, like I said, the normal disc area is about 1.75 millimeters. This one was way down here at 1.2, 1.3. So keep in mind what's the normal disc area. I think that'll help you. Okay, I think any quick questions, we'll have lunch for an hour. Anything else about that? So we're covering artifacts, nerve fiber layer analysis, and putting that together with the ganglion cell and the visual field. So I think incorporating those things can help.
Do you have any written language for these?
Yes. So one of the PDFs that Rafi posted for you is a review we wrote on artifacts and how to interpret OCT. So it's all there for you. Yeah. Okay, great.
Thank you.
Let's take a break. Yeah.